She's extremely active in the field of education. She's a professor of ONG at St. George's, director of fetal medicine at Liverpool Hospital, a trustee on the board of ISUOG, very widely published. I don't know of anybody who's published as widely as Asma for her stage, and don't call it training, but a stage in her career. And is the vice president for academia and strategy at the college. So Asma wears many hats and is extremely active in the field of education. So in the terms of putting the program together, there are three sort of very relevant things that we see in the third trimester that are challenging. And again, Asma has published on all of these, and just the right person for the job to cover the topic of achondroplasia, bowel obstruction, and vein of GALEN. Asma, over to you.
So dear colleagues and friends, this talk will cover vein of GALEN, achondroplasia, and bowel obstruction. What are the links? Is the link between the three anomalies? Well, they all usually diagnosed often in the first time in the third trimester. So the instance of fetal anomalies detected or diagnosed or seen in the third trimester, according to this screening study that was performed routine ultrasound scan, about between 35 and 37 weeks, was about 2%. If you look at this 2%, about nearly 70% or 2/3 of these cases were already diagnosed in the first or the second trimester, but a quarter of these abnormalities were diagnosed for the first time in the third trimester, and about 7% were only detected postnatally. And there's always this question about what is the value of detecting fetal abnormalities in the third trimester, and there are a number of potential benefits, including improving the postnatal outcomes. So, for example, some of these abnormalities, if you identify prenatally, you will make sure that you plan the delivery at a certain time, and particularly at a place where there is the facility for maybe immediate peripartum intervention, or maybe doing postnatal investigations. And in some cases, you could actually offer a fetal intervention that could improve the outcomes. And of course, we mustn't shy away that there will be some cases where there is potential option of termination of the pregnancy. So the vein of GALEN aneurysm diagnosis, again, usually in the third trimester, diagnosis is really easy. It's in axial view of the fetal head, and you see the supratentorial midline translucent elongated cyst. And the key thing, when you put the color Doppler, when you see this active arteriovenous flow within the cyst. So the diagnosis is really easy. And why is important? It is the most common CNS vascular abnormality detected prenatally. The incidence is about approximately 1 in 50,000 live births, and this constitutes about 1/3 of pediatric congenital vascular anomalies. The embryology of the vein of GALEN aneurysmal malformation really stems from the fact that it is arteriovenous fistula. So the main drainage of the choroid plexus. And this is a really nice article. And in this figure, you see this is the median prosencephalic vein of Markowski. And normally, this is anterior, posterior. Normally, the anterior part will actually should regress, and the dorsal segment would develop into vein of GALEN in adult, like what you see in adult. But in cases or fetuses where they have the vein of GALEN or develop vein of GALEN and arterial malformation, what happens is that really early in the pregnancy, in the first trimester, around 6 to 11 weeks, there is this disruption in the early embryological pathway of these cerebral vessels, and that leads into this arteriovenous fistulas between the choroidal circulation and this prosencephalic vein of Markowski. And therefore, that obviously leads to a shunt of the fluid and a result into the ultimate formation of the vein of GALEN arterial malformation. And is it inherited? Well, not usually, and the risk of recurrence is not increased in future pregnancies, but certainly there evidence to support that it does have genetic origin. So in this paper, there's de novo mutation in chromatin modifier genes and the Ephrin type B receptor 4, and this is now considered as or seen as probable significant genetic contributions to the development of vein of GALEN arterial malformation. There are two morphological types. It's more, we don't really see it on a prenatal ultrasound scan, but that potentially explains why some cases more likely to have heart failure and some cases don't. So this is the choroidal type, where actually you see many choroidal arteries open into the venous pouch, and that's resulting in heart failure in most of the cases. While the mural type, where there is simple arteriovenous fistulas in the wall of GALEN vein, and that rarely actually causes severe intrauterine symptoms. So what is the problem with the vein of GALEN arterial malformation? Well, the fact that they have this hyperdynamic circulation, and therefore that can result in heart failure and fetal hydrops. Some of these cases, about a third of the cases, they will have ventriculomegaly, and that's because of the increase in the venous pressure, so that reduces the CSF resorption, but also the fact that there's compression and obstruction of the salvia of the aqueduct by the dilated vein of GALEN. And also the fact that they can have secondary brain lesions, and that because of chronic venous congestion and ischemia, and that can cause destruction of the white matter. And in the ultimate form, you have this melting brain syndrome, where again, as a mechanism, as I mentioned, is chronic venous congestion and ischemia that leads to destruction of the brain tissue and volume loss of the periventricular white matter, which is a key really diagnostic feature in melting brain syndrome. As you can see in this MRI images from two cases, we have this, you have the vein of GALEN malformation, there is ventriculomegaly, the dilated torque, but here the key is they have this loss of volume, reduced volume of the periventricular white matter, and the same in this case, again, in this it's reduced volume of the periventricular white matter, the melting brain syndrome. I mentioned earlier that this the hyperdynamic circulation lead to cardiac changes and ultimately heart failure. So, and therefore, whenever you have vein of GALEN, you need to look at the heart and even do a fetal echo, because there are a number of a list of cardiac changes that you could come across in the form of cardiomegaly, in form of the dilated the right side of the heart, there's not the tricuspid regurgitation, the dilated, markedly dilated vessels like the superior vena cava, the jugular vessels. There is impaired right ventricular systolic function, and you see the reverse flow in aortic arch. How common are the associated ultrasound abnormalities or findings? In the ventriculomegaly is reported in about a third of the cases. The cardiac change is about a quarter of the cases, and in extreme form, obviously hydrops was associated with increased perinatal mortality. Most of the cases, about more than 70% of the case predicted prenatally. The prognosis is, it is divided into 3/3. 1/3 of these babies die, often postnatally, and 1/3 they survive and they have good outcome after postnatal intervention, and about 1/3 they survive but they have neurodevelopmental delay. And therefore, once you make the diagnosis, and the diagnosis is very easy, because you have this big cystic structure in the midline and the axial view of the fetal head, you put the color, and then now you need to define sort of to do detailed neurosonography or MRI, looking for associated brain abnormalities or lesions, echo to look for early signs of heart failure. How often should I see this patient? Weekly ultrasound, because you're looking for the signs of heart failure or deterioration. And if you have hydrops, that's obviously a sign of very poor prognosis with high mortality. And this case should be delivering around 38 weeks by cesarean section. Very importantly, in a place where obviously you have neonatal unit facilities and specialist pediatric neurosurgery, because they require postnatal intervention. A number of studies looked at or reported about the prognostic features, and of course, if you have associated brain lesions, it's the prognosis is worse. If you have tricuspid regurgitation, and then some studies sort of reported contradicting results. Some said the diameter of the straight or falcine sinus is predictor. Obviously, the larger the worse outcome, and some suggest actually the volume of the vein of GALEN. Until a few years ago, a couple of years ago, the treatment is mainly, or the intervention is postnatally in the form of embolization of the vein of GALEN malformation. This was the first report of a fetal intervention come from the United States, from the Boston Children's Hospital, of actually ultrasound-guided transuterine embolization of the vein of GALEN. And in this case, successful outcome did not require postnatal treatment, and the outcome was very good. And the team led by Darren Orbach went on to have set up the study. This is a protocol, it's published, it's a prospective, it's a single arm, it's non-randomized intervention study. And that means to assess really the safety and efficacy of this intervention, which is in the form of embolization of the vein of GALEN malformation. It started recruitment on the 30th of September 2022, expected to complete recruitment in 2025. And the technique, as you can see on the right side, this is an MRI image where basically ultrasound guided. You pass this needle, 19-gauge needle, transuterine. You go to the confluence of the sinuses, and that allows you access the varix, and through that you pass. So this is the red is a needle, and then you pass the microcatheter, which is the blue. And this microcatheter will allow you to deliver the coils, which are in green color, and this is a coil for embolization. About a few months after, about 6 months after the publication by the American team, and the French team published another case where they had the prenatal treatment of GALEN. This case required postnatal intervention, but the baby survived. It was a good outcome. And we published this paper in White Journal a few months ago, where we actually looked at the literature, but also reported this case from Poland, from the team led by Robert Samaha, where this case was referred at 26 weeks. This is a vein of GALEN malformation. You can see the size is just about under 2 centimeters. There's already cardiomegaly, already the dilated vessels, the jugular veins, superior vena cava. This is the MRI image of the vein of GALEN malformation. As you can see, there was no ventriculomegaly. There were no associated brain abnormalities. And 29 weeks has progressed, so the size of the vein is increased. And also there was early signs of heart failure. A week later, there's early signs of hydrops. And the mother, despite being non-intensive, started developing perhaps early signs of maybe potentially Merer syndrome and raised liver enzymes. And at that point, because of also the early signs of hydrops, there was an MDT, and there was a decision for offering fetal intervention. The technique is similar to the technique that was described by the American team and the French team. In this case, they had general anesthetic. The other two was epidural, spinal, intramuscular anesthesia for the fetus, and ultrasound guided. You pass the needle here. You go into the sinus confluence, and you pass this microcatheter, and through the microcatheter you deploy these coils, and these coils are used for the embolization. In this case, they put 12 detachable coils. 48 hours post-operative, it was successful. Surgery in terms of decreasing the blood flow in the vein of GALEN malformation, improvement in fetal cardiac function. But the mother starts developing what probably like health syndromes by being intensive. There's raised liver enzymes, there's raised lactate dehydrogenase, LDH, and also very high SPLT1 LGF ratio. And unfortunately, the following day, there was a diagnosis of intrauterine fetal demise, and the further one was induced. This is a post-mortem X-ray and autopsy, and you can see the coils here in the correct position. And the mother obviously developed hypertension after delivery. So successful surgery, but unfortunately, baby died. In this paper that we published, we did really wanted to highlight that the literature could potentially be biased, because only really cases with good outcomes get published. Well, what about the cases that actually have bad outcome? And highlighting these 2 published cases that were presented in FMF World Congress in June 2023 by Rogelio Cruz Martinez, published its reported or presented these 2 cases that had successful fetal intervention, same technique, but unfortunately died postnatally due to renal failure. In this paper, we did compare really the fine details of these 2 cases, the cases from the United States and the cases from France. I'm not going to go through it because of the time. I'm going to move on to achondroplasia. And achondroplasia, it is the most common non-lethal skeletal dysplasia, and result because of mutation in the FGFR gene. It does have autosomal dominant inheritance, and it's often can be diagnosed by doing amniocentesis, testing for the gene mutation, or actually nowadays you can do non-invasive maternal self-read DNA in the maternal blood. Of course, it's dominance. You need only one abnormal gene, and that's a heterozygous. And these children tend to be dwarf, but they have normal intelligence and life expectancy. They can have morbidity. They have stenotic vertebral canal, but now there is a trial of postnatal treatment. But if it's homozygous, if the two parents have achondroplasia and they pass the faulty gene, that means it's homozygous, and these cases are lethal because of the severe pulmonary hyperplasia. What about prenatally? Well, obviously, most of the cases are diagnosed in the third trimester because this is where you actually see the severe shortening of the long bones for the first time. And but only about a third of the cases, the femur is also bowed. A majority, 90%, they have frontal bossing. They can have short fingers, a trident hand, and about 70% of them, they have large heads, and a third the cases have small chests, and about 2/3 of the cases, they could also have polyhydramnios. I think one feature that I'd like to highlight in this talk is the fact that the fetuses with achondroplasia, they tend to have a wide proximal femoral angle. So this is in normal babies, and you see this angle compared to this angle. So in babies with achondroplasia, you see it's much wider or much more obtuse. And we published this study about 10 years ago. We reported that fetuses with achondroplasia at the time of the diagnosis, if you measure this femoral proximal diaphysis between the diaphysis and the metaphysis angle, it's much wider or obtuse compared to controls, so normal fetuses, or compared to other fetuses that could be in similar situation. They have short femur in the third trimester. There's a cohort of trisomy 21 and also a cohort of skeletal dysplasias. And if you, between trisomy 21 and the normal fetus or controls, there's no difference in this angle. Again, between skeletal dysplasia and no controls, no difference. While actually achondroplasia, when you compare to other types of skeletal dysplasia, like somatophoric dysplasia, or Jones dystrophy, or osteogenesis imperfecta, the angle was much wider. We went on and tried to see whether we can actually use that as a marker in the second trimester. So at 20 to 24 weeks, for the time, often the femur is still within normal range. Is this angle tend to be wider? And the answer is yes. In this research letter, a small number, so it needs to be obviously validated in a larger cohort, but actually this angle with wider in fetuses when had diagnosis of achondroplasia later in pregnancy compared to normal fetuses. For achondroplasia, if it is a de novo mutation, the risk of recurrence is low, but actually if one of the parents affected, the risk of recurrence is 50-50, and if the both parents are affected, the chance of heterozygous, so affected baby or fetus, about 50%. But of course, if both of them pass on the faulty gene, that means homozygous, chance is 1 in 4, and that's lethal, as I mentioned earlier, and about 1 in 4, the fetus would be unaffected. Moving on to bowel obstruction, which is the last part of this talk, I'm highlighting that there are typical features or ultrasound diagnostic criteria of bowel obstruction, which are common, so dilated bowel, polyhydramnios, or both. But there's also the atypical or uncommon diagnostic criteria or ultrasound features that you need to be aware of in the form of meconium peritonitis, meconium pseudocyst, and ascites or hydrops. Very important basic sort of feature or basic fact, how you differentiate between small bowel and large bowel on ultrasound scan. Well, obviously, small bowel have a smaller lumen caliber, the plica circularis, the fluid content, and obviously the peristalsis. So those are features. If you have a dilated tube of bowel, it's a small bowel or large bowel. How do you define actually dilated bowel? Do we have a reference range? And the answer is yes. So in this study, you see obviously it varies with gestational age by diameter by 42 weeks. A small bowel, the average about 5 mm and maximum is about 8 mm. The large bowel is about average is 15 mm, maximum is about 19 mm. Very important is the fact that the longitudinal changes. So in this study, you see that in fetuses with suspected dilated bowel, if you follow them up, the one that were stable or even regressed had no bowel pathology, while the one that progressed is the one that had the bowel pathology. So importance of doing longitudinal assessment and follow-up ultrasound scans. So in this study, the one that had a normal neonatal outcome in about more than half the cases, actually the bowel dilatation resolved on follow-up scans, while the cases that had progressive dilatation, they all had pathology needed postnatal intervention. Then, what about the presence of polyhydramnios? Is it a reliable marker or feature of bowel obstruction? Answer is not. And in only present about half of the cases of jejunal atresia and about a quarter of the cases of jejunal ileal atresia. So it's not really a reliable feature on ultrasound scan. And how good is the prenatal ultrasound scan in diagnosing jejunal or ileal atresia? We published this paper again about 9 years ago. The detection rate for jejunal atresia is only about 66%, and ileal atresia is only about 25%. So, but certainly the most reliable feature if you have a combination of dilated bowel and polyhydramnios. What about pyloric atresia? So in this case, you have a dilated stomach, you have polyhydramnios, and be careful because the possibility of genetic abnormality, but particularly something called Carmi syndrome, which is a result because of the mutation in the IGTP4. In this case, you have pyloric atresia, so you have dilated stomach, you have the polyhydramnios, but important, the polyhydramnios have this snowflake appearance, which sort of remind me of the appearance of amniotic fluid in cases of acrania, for example. The Carmi syndrome, it's important to know about it because the recurrence risk is about 1 in 4. It's autosomal recessive. And there are a number of genes that can result into Carmi syndrome, but the majority, 80%, is because of this integrin beta-4 mutation. And the clues, you have the family history is important. So also there is raised alpha protein acetylcholine levels, but features of pyloric stenosis, dilated stomach, the polyhydramnios, and the polyhydramnios have this snowflake echogenicity. And in this case, make sure that you look for associated abnormalities, particularly the kidneys and the ear. The jejunal atresia, you have the classic double bubble sign, often after 24 weeks, often present in the third trimester, and polyhydramnios occurs in about half of these cases. And of course, there's a common association with Down syndrome or chromosomal abnormalities reported in about 1/3 of the cases. But it's important that we know that in the current era of wide implementation of the NIPT or the cell-free DNA early pregnancy, this association is much less. Because often most of the cases of Down syndrome are diagnosed early in pregnancy. So if you have a jejunal atresia diagnosed in the third trimester, the chance of Down syndrome is definitely not 30–40%, is much less, which is what we demonstrated by our data in this article. Don't forget that there is a risk of associated abnormalities, particularly heart, kidney, and vertebra, which is reported in about 10–20% of the cases. When you have the jejunal atresia, if they develop severe polyhydramnios and the mother is symptomatic or have short cervix, that will be an indication to offer amnio drainage. We should make sure that we deliver in a center where there is obviously needed intensive care unit and access to pediatric surgery. And there's no indication for delivering early, so usually about 38 weeks, but the risk of preterm birth is high because of the polyhydramnios. There's not an indication to do cesarean section. Survival is more than 95%. And if it's isolated, there's an increased risk of recurrence. But if it is associated with trisomy 21, the risk of recurrence is 1%. Very important is this potential unusual or atypical presentation of cases of bowel obstruction, which is often because of the risk of perforation. Perforation can present as ascites, and the natural history developing meconium, peritonitis, or meconium pseudocyst. And therefore, what you see on ultrasound, it depends at what stage in this natural history that you scan the patient or the baby. Very important, don't forget testing for cystic fibrosis. And because cystic fibrosis reported in about varying instance really in case of meconium peritonitis range between 15–40%, or reported even some studies in 75%. So make sure that you don't forget testing for cystic fibrosis. Why cases of fetal with cystic fibrosis will have meconium peritonitis is because in cystic fibrosis you have this dehydrated, thick meconium that causes obstruction of the lumen of the bowel and therefore result into a picture of bowel obstruction. This is a treatment. This study reported the prenatal treatment of the meconium peritonitis with this urinary trypsin inhibitor. And the idea, the fact that this meconium have digestive enzymes such as the trypsin, and that causes aseptic peritonitis, and that causes this extensive inflammation that prevent the spontaneous sealing of this perforation, and that the fact that this inflammation causes bowel edema and therefore aggravate the underlying bowel obstruction. And if you have this, we give urinary trypsin inhibitors, so this anti-inflammatory can actually reduce the inflammatory process and therefore improve the picture of the meconium peritonitis. And this is the case that was reported. When you see old images, you see the meconium peritonitis, and 1 day after the treatment with the urinary trypsin, you see there is improvement, and 4 days after treatment, again, significant improvement. What about, is this actually genetic association? And despite the fact there's no really well-defined gene mutation, this case, interesting case that actually highlight this potential of potential inheritance or genetic as a link. So it's a really sad story. The couple, consanguineous couple, first pregnancy, presented with ascites in the mid-trimester. They did paracentesis. It was meconium stained, and at 28 weeks, it was a picture of meconium peritonitis. So delivered at 36 weeks, and unfortunately, baby died in the neonatal period. And 8 years later, the couple presented with a second pregnancy. And again, there was a feature of recurrent bowel obstruction and had termination of the pregnancy, and the postmortem confirmed small bowel obstruction. So I'm going to stop here. I hope I had covered the vein of GALEN, achondroplasia, and the bowel obstruction. And I'm going to stop here. Thank you very much for your attention, and I'm happy to take any questions.